Our next presentation is entitled Neutrophil-to-lymphocyte ratio is a superior prognostic marker to frailty in patients undergoing open lower extremity revascularization, presented by Dr. Adler and colleagues with senior author Dr. Beckerman from the Rutgers Robert Wood Johnson Medical School in New Jersey.
Hi, everyone. Thank you so much for the opportunity to present today. My name is Lily Adler, and I'm a third-year medical student at Rutgers Robert Wood Johnson. And I'm here to present our work entitled Neutrophil-to-lymphocyte ratio is a superior prognostic marker to frailty in patients undergoing open lower extremity revascularization. So just some background, neutrophil-to-lymphocyte ratio, or NLR, is a low-cost and easily attainable marker of preoperative inflammation taken just from a CBC with differential. And NLR has been shown to be a clinically significant predictor of postoperative outcomes in a range of vascular surgery procedures, including carotid endarterectomy, EVAR, and open lower extremity revasc. So there is no accepted value for an NLR. Normal values are considered to be 1 to 3, but there isn't one cutoff point. So our prior work showed that there was a maximal cutoff point in NLR of 4.6, which maximized the difference in mortality between two groups in patients undergoing open lower extremity revascularization. And what we found is that NLR is an independent predictor of mortality when controlling for multiple comorbidities using that cutoff point. But NLR has never been compared to validated risk calculators like Frailty. So the objective of this study is to determine how NLR compares to Frailty as a preoperative risk assessment tool in open lower extremity revasc. So a little bit of background on Frailty. So Frailty is a way of quantifying the loss of physiologic resilience that results in increased risk of adverse outcomes when experiencing stressors like surgery. And the Modified Frailty Index is a validated risk assessment tool derived from the criteria used in the Canadian Study of Health and Aging, so it's very fitting to be giving this talk here. And the MFI-11 uses 11 characteristics to determine frailty, where you're considered frail if you have 3 or more of those characteristics. So we conducted a retrospective study with 260 patients, and NLR was calculated within 6 months of the date of surgery, with the date closest to the surgery used if multiple data points were available. Our primary outcome was death, and secondary outcomes included major adverse limb event and hospital length of stay. The median time prior to surgery of the CBC was 5 days. Our median MFI was 0.36, which correlates to 4 of those 11 characteristics. And as you can see, the majority of this patient population is frail. When we compared the characteristics of the different groups, we found that there was no difference in the NLR between the frail and not frail group. We did find that both the low NLR, that the high NLR group was considered more frail than the low NLR group. Both the frail group and the high NLR group were statistically older. And this was kind of surprising, but there were higher rates of smoking in the not frail and in the low NLR groups. There was no difference in the preoperative Rutherford classifications, the case class, the procedure type, or the surgery duration between all of the groups. And we did find that frailty was not independently predictive of mortality, but that NLR was, both as a continuous variable and as a dichotomous variable. Frailty also did not correlate with major adverse limb event, and neither did NLR, but infection did. When we compared the outcomes between our groups, we did find that high NLR was associated with a longer hospital length of stay, of median time of 7 days compared to 4 days in the low NLR group, but that the length of stay did not differ when using frailty. So limitations of frailty. So most patients undergoing vascular surgery qualify as frail. If you have diabetes, hypertension, and peripheral vascular disease, which the vast majority of these patients do have, you automatically already qualify as frail. And frailty treats each characteristic as a binary rather than incorporating disease severity. So again, this doesn't take into account how well managed diabetes is. It's just whether or not you are diabetic. So in conclusion, frailty is not independently predictive of mortality, while NLR is. Frailty, as currently defined, is not clinically useful in the vascular surgery setting because it is not differentiating in this particular patient population. It's also unlikely to change with time. So if you're diagnosed with diabetes, you don't get undiagnosed, but if you have better control, that's not really reflected in the NLR. So we think that NLR is better. Limitations of our study here are we were limited by the retrospective nature of the research. We were limited by the time at which blood was drawn prior to the surgery. Also, I will note that this NLR cutoff point has not been validated, and that NLR is only a surrogate marker of inflammation. So our next steps are to validate this NLR cutoff point, to consider some other definitions of frailty, and to compare NLR to other inflammatory markers. Thank you so much, and thank you to my mentor, Dr. Beckerman, as well.
Okay, while we're waiting for somebody else to come up with a question, very nice presentation. I was just wondering if you guys could comment on the time issue of when the blood draw is a little bit further. I think, as I've read, work in this space with NLR, it's often retrospective. And so how do you address that time point, like going forward? Are you guys thinking of prospective data collection? Like, how do you get to that question with a more specific answer of when you need to draw that data to understand the process?
Yeah, I think that's a great question. This was kind of the frustrating part. So we actually had we lost a lot of patients because we couldn't find a CBC in the retrospective chart review within, the 6-month period. It's not to say that it wasn't done. It just, we didn't find that when we were going back through. So I think that is a major limitation. I will say that our median for the population was 5 days. So that's a kind of appropriate level of time. But I think doing this prospectively would be great. I think there are a number of papers now that have come out showing that NLR is clinically significant. And I think the kind of next step is to make this useful and to think about, how to set that. And part of that will be doing this prospectively. So yeah, it would be great to do it prospectively.
Yeah, hi, Bjorn Zuko from Dartmouth. So frailty, in my book, is more of a way to objectively measure the gestalt I have of a patient. Should or should I not operate on them? Yeah. Or should I choose option A or B? All these people had option A, which was an open revasc. So in my mind, frailty here doesn't really help me differentiate between options. NLR, I don't know what to do with. That seems to be more of an acute measure of an inflammatory response. To what? Do they have a UTI? Do they have a viral respiratory infection? Can I treat this? Can I make it get better and then get them through surgery? What do I do with this NLR? How will that help me preoperatively decide, should I operate or what operation should I pick for my patient?
Yeah, thank you so much for that question. I think that is kind of the most important question. So to tackle the first one about operative decision making, so for instance, there was a paper that came out looking at carotid endarterectomy, and this suggested that NLR could be used to decide who should undergo surgery versus medical management in patients with asymptomatic carotid stenosis. We were looking at patients all who were operated on, but I do think that actually this could be used to suggest that if they're really bad rates, if you have an elevated NLR, that maybe some of these patients who were operated on shouldn't have been operated on. And my understanding is that some of the outcomes of these in general, like 5-year mortality, is generally pretty bad with chronic limb-threatening ischemia. So kind of having a better sense of the risk profile could actually be useful in this particular population. That's kind of the first part. And the second part is, I think the fact that that it is an acute marker means that there might be, there's some places that have these kind of like preoperative clinics that help to optimize patients for surgery. And I think, we need to kind of look at doing that. If they do have an underlying infection and maybe this will pick that up sooner than you've diagnosed a UTI, and maybe there's a reason to pause the surgery to try to figure out if there is a way to better optimize someone prior to surgery. I don't think we're there, we don't know exactly what that looks like quite yet, but I think that there is something here to look closer at.
Okay, one more comment from Dr. Lee.
Very nicely presented. Did you look at other markers of frailty? I think that there's probably several people in the room that have been working on RAI, which one of our faculty has really made her sort of career out of it. And I wonder if you just weren't comparing to something that now, through multiple studies, VA co-op studies, R01-funded studies, people are looking at a different marker.
Yeah, so that's one of our plans, is to look at some of these other definitions and kind of markers of frailty. There was a paper that came out recently as well that kind of suggested a new definition. There's different criteria have been suggested, like including anemia and various things. So I think definitely there's a possibility of improving frailty. This was kind of just the start to kind of look at this, but certainly not the end of the conversation. And it's definitely worth comparing NLR further to some of these other preoperative risk metrics.
Thank you.
Thank you.